Today's guest is Dr. Cristina Hickman, a pioneering consultant embryologist and a global leader in fertility innovation. Dr. Cristina is also the founder of Avenues, the world's first AI-powered reproductive care clinic in London, designed from the ground up to combine the strengths of AI with the empathy of human connection. In an area where outcomes can be unpredictable and the emotional stakes are high, Dr. Cristina's work is designed to augment clinical decision-making with technology that sees what the human eye can't, and to bring clarity to a process too often shaped by trial, error, and sheer luck. Dr. Cristina, thank you so much for being a guest on the podcast today. I'm so happy to have you.
Oh, it's a real honor to be here. Thank you for the invitation, and I'm really looking forward to our conversation.
Me too. I'm so intrigued by your work, AI in the field of reproductive care. Can you tell me a little bit about what that means? Like, what gave you the idea? Like, do you remember the moment you were, well, actually, we can deploy AI in what I do?
Yeah, look, I've been in this field now for 25 years. I've worked with the biggest groups of clinics out there, and there's a lot of subjectivity in how we make our decisions. I mean, we all expect this to be all based on science, but there's a lot of opinion on the decision making, some of which are critical in establishing whether this is going to be a cycle that's going to lead to a baby or not. So the stakes are really high, in making the right decision. When you ask 5 different embryologists, and literally we did that study, we published this in Nature. We asked 5 different embryologists to grade the same embryos. We only agree in less than a quarter of those embryos being graded. So when patients are being told the quality of an embryo, it's not going to be a consistent answer depending on what country they're being treated in, what embryologist is in front of them, and so on. So we really need an international language. So all of us are saying this, we're speaking the same language in terms of the quality of this embryo. I've come from a data-driven background, so I've always been very mathematical as well as biological, which is unusual. Usually it's on one side or the other. And I have a background in oceanography and marine biology, so I've always been wanting to seek and predict what's going to happen next. So in my 25 years in embryology, we've really been looking at what are the pieces of information that are going to help us get there. And this went from just looking at embryos to when time lapse came in and started taking pictures of the embryos. But then we started taking pictures over a 7-day period, over 11 focal planes. So collecting 2.6 billion data points, right? Huge amounts of data. And it's when this technology came in that I started to realize that out of these 2.6 billion data points, different embryologists were focusing on different data points. So not only were we establishing quality because we disagreed, even when we're looking at the same thing, but now we're looking at it from different angles, and everybody had a favorite angle to look at. So that made matters worse. It was more data, making things even more subjective. So the moments that I realized AI was going to help was when I was in a plane flying from Brazil over to the UK. I was coming back from a conference, and next to me was a mathematician specialized in AI. And we started talking. So his work was about trying to predict air particles going over the wing of an airplane. Nothing to do with the biology, right?
No.
And here I am telling him about my pain points of I've got so much data. I've got all this information. And he goes, send me some. So we got patients' permissions. We went for ethics approval for our research, and I sent him some. And suddenly he made the previous 10 years of my life completely obsolete. So the research that we've done of different little cue points that we had here and there to predict. And just like that, AI was able to predict better than me. And that, I didn't take it personally. It was actually a good thing, for patients, and it was a good thing. And that just got me hooked. So we were one of the first to present that AI is a hope. And we've been ever since trying to get the rest of the world to kind of catch up with using AI. So back then it was just embryos, but now we're looking at embryos, we're looking at ultrasound, we're looking at blood tests with AI, we're looking at genetics with AI. So when we start looking holistically at all of these different angles, it starts opening doors to answers that were never there before. So it's been a really exciting journey, and to be able to build a clinic designed around this technology has been something that's then allowed the whole benefits of these technologies to catapult even further.
What does this mean for a woman that comes to Avenues? All of this AI powered extreme efficiency. Does this mean that fewer rounds of IVF potentially for them to have a successful pregnancy? Like, how does this affect their lives?
So it's important to highlight that the fact that you're looking at an embryo and analyzing an embryo is not going to make that embryo better.
Mm.
Okay, so the thoughts that by analyzing with AI is going to increase your success rate is not there directly. It's more indirect. What it does is it allows us to better understand why things aren't working, and it also allows us to predict that things are not going to work. What you need to understand is that the majority of patients that quit IVF care, because IVF is not a single cycle, it's multiple cycles in a journey. The vast majority of patients are going to require multiple cycles to get to that baby. So the important thing to consider in this context is that the information will help us manage the journey as a whole.
Mm.
The definitions of success that most clinics use, which is per cycle or per embryo transferred, AI can't help there. But if we redefine success on, I'm going to reduce the cost to baby, and I'm going to increase the time decrease the time to baby, and on top of all that, I'm going to create some extra bits of information so the patient can understand the why of their own biology, so they can understand their own potential and start putting together a plan that's aligned with the limitations of their body. Because there is no such thing as a perfect body. We know that now, because the more data that we're capturing from a patient, the more we start seeing this is not ideal and this is not ideal. And that's okay. Perfection is not possible in humanity. What we're doing is identifying those challenges and then putting together the right plan to fit that challenge. And that's where the patient will see the benefits. They see the benefit of understanding their why and then looking at the right journey. So examples of this would be patients that are told there's no way they can conceive with their own sperm, go for sperm donation. And they come here and we're like, no, 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 we have an AI tool and we can search for those really rare sperm that are going to be in your particular sample. And with this AI tool, we can give you a chance. Let us give it a go. I know you've been doing sperm donation for several cycles. Let us give it a go. And then we have several examples where we've been able to revert patients back into using their own eggs or sperm, and they're all either pregnant or on the verge of giving birth. So this is something
Amazing.
that gives hope and it gives an additional option. But the reverse is also true, right? So if a patient is coming to freeze their eggs, so let's say I got two patients freezing the eggs. The first one has 17 eggs, right? She's going to come back in 10 years' time to warm them, but we need to make a decision now. The whole idea is that we preserve her potential now. So most clinics, they'll look at it and go, she's got 17 eggs. You don't need any more. You're good to go. We look at the quality of each individual egg. So we'll turn around and say, look, I know you got 17. I know 17 is a good number, but the quality is not there. So with these 17, the AI is telling us that this is your chance of having a blastocyst and this is your chance of having a baby. Is this chance a number that you're comfortable with? And there isn't really a cutoff that we say above this number. No. We sit with the patient. The patient takes the driving seat, right? And we advise them, these are your options. These are what we can help you with technology. What feels right for you, right? Given this is all the information you need to make the decision. This is all the information we have available. And that wasn't there before.
Yeah.
So before it would be just, you got 17. Meanwhile, like the next call is a patient who's only got 6. Most doctors will be telling her do another cycle. We're like, I don't know. These are really high quality. You don't have to spend your precious money doing another cycle. You have already this percentage chance. Is this high enough for you? And if we were to go to another cycle, you're not going to increase that much your chances of having a single baby.
That's just blown my mind, because I was talking to someone about the pros and cons of freezing your eggs, and they were like, there's a 10% chance, maybe 5% chance that the eggs ever being of good enough quality to end up in a pregnancy. So why would you waste your money? I was shocked by that. And I actually was thinking, oh, well, That doesn't seem like really great odds, but now you're telling me actually there's a chance of using your technology to be able to maximize your chances. And I just think that that's incredible. And more people should be knowing that.
That's exactly, and for instance, looking at the UK data, okay, so there's about 500,000 cycles. There's a million cycles in the database, but 500,000 that is better data that we can look at. And in there, we already know, at least more recently, 33% of patients going through IVF on average across the board are going to go home with a baby. So, but that is on a per cycle basis. If we now start looking at it across a journey, those numbers could look like 68%, 80%. Not because we are increasing the chance per cycle, because we're being more strategic on how we are treating this patient. And if we start preparing these journeys in a multi-cycle, not just from a medical perspective, but from a financial perspective, this means that we can preempt the journey as a whole and prepare the patients as opposed to them spending 10K, 10K, 10K. Suddenly they spend 100 grand. I mean, these are the sort of figures that these patients are spending. We can preempt that, say, no. We now have a strategy. Instead of spending 100 grand, we have a journey for you because you have a particular challenging condition where that journey is going to be 18,949, right? So this is something that we are really tailoring the right package for the right patient from a financial perspective as well, without hidden costs. This is what is the other horrible thing that we have in our field, is that there's a complete lack of transparency. And you go in thinking you're going to pay £4,000 because that's what they're advertising, but you leave, the average cycle cost in the UK is £9,400. But the clinics are advertising £4,000. So there's an extra surprise £5,000 that pops in during the journey that the patients haven't factored in. So one of the things we've been working on, how do you create these packages that look like not on a per cycle, but the whole journey, unique for each patient? So this patient has a really complex approach. It's going to be £18,000, but this other patient, for her, it's going to be only 2,949. We've identified like a group of patients that you can turn around and not have to throw everything but the kitchen sink. We don't need to overcomplicate their treatment. We're still maximizing their chance of success. In no way is a chance of success compromised, but she's not being given technologies that are not going to bring benefit to her situation. Now, this 2,949 is something that can support about 75% of people who suffer from infertility, but never seek help because it's so expensive to them, right? So 75% never come to see the doctor. They've been turned down by the NHS and they stop there. But this 75% we can help. And this 75% can fit the 2,949. They can pay that over 12 months, £200 a month, right? So this is something that we're finally making IVF accessible in a market that is incredibly unfair because some people can't have a baby because they have the means. Other people can have a baby because they happen to live in the right neighborhood that has the NHS funding for them. And then the other person is living across the road and doesn't get the cutoff to get that NHS funding, and they have to pay it themselves. The UK is really unfair from that perspective. So we really want to make it that if you want to have a baby, you should be able to have a baby. And we're here kind of to support these patients. And, I wish that IVF could be completely free, but we're trying to get as close to that as we possibly can so we can have that impact and help as many people out there as possible.
That's amazing. That's amazing. I was also thinking, as you were speaking, does this also, in terms of the pressure that women face, like, oh, you're 30, you need to start having a baby now, or you're 35, this is the end. If you've not freezed your eggs, that's the end of the road for you. You hear these scaremongering stats sometimes as a woman, and people are trying to be helpful. They're like, this is how you plan. But I feel like with your technology, coming up with a strategy for someone who might be considered as a disadvantaged position because of timing or other medical factors, I feel like you can give them the best way forward. Whatever disadvantages they have, you can turn that into something that it feels more like, oh, I have a shot.
Exactly. So my fertility story is that, my plan was I was going to study, I was going to do a PhD, and children was going to be later. That was my plan A. Okay.
Yeah.
But I was lucky enough that I'm Brazilian and we had private healthcare. And in Brazil, you go to see your gynecologist before you even have your first period, and you get to understand your body. This is something that I wish was the reality for every woman in
Mm.
this world, right? And in doing that, I knew that for me, I would struggle to have children later. And if I wanted to have a family, if I wanted to have children without needing donation, without needing the support of IVF, I knew from those discussions, from the tests that I did as a teenager and later on as a young adult, that I would have to do this earlier. So I changed my plans. I had my children when I was 24. I was the youngest mother in the world, right? It was, and that became my new journey. So I had my children whilst I was doing my PhD. I just
Wow.
had to kind of balance the two together and change all the plans in my life. Now, I did that educated decision and I planned my life accordingly so that I had my children early. But if every woman could do that, it means that they could put their own plan. They can, and not everybody needs to be freezing their eggs, but you should at least have an understanding of whether that would be a right strategy for you.
Yeah.
So it all starts with doing an assessment of your fertility. And one of the worries I have is that you do have a lot of products out there. You can get these products off the shelf of supermarkets, sort of thing, and they lack the detail that you kind of need to make a proper assessment of your fertility, which means that it might give you this false reassurance that everything is okay, and it might lead you to do the wrong plan. So we have spent a lot of time putting together what is the optimal tests that a person should do to be able to truly understand and truly plan. So know your potential, know what your target is, find the right plan that is for you, right? So that understanding, it's called reproductive intelligence, right? So we know our IQ. You need to know your reproductive intelligence as well.
Mm.
So this means that we have the ability that patient can know their semen parameters, because the other problem is that people will just test the woman, not the man.
Yeah.
So our kids test both, whether you're two women, two men, a man or a woman. But the point is that you understand all the ingredients coming into making that baby. So we have a semen test, which we don't just look at the usual parameters that everybody else looks. We use AI to assess and to be predictive of what this means for clinical decision making. So that's the first step. The second step is looking at your hormones, getting an understanding of what's happening at a hormonal level. And we worry about some products out there that only look at hormones, but don't look at the rest. So that gives you an incomplete picture. And the third thing is that they then come in to do a full AI-driven 3D scan of the entire pelvic region, so you can understand what is happening with your uterus, what is happening with your lining, what is happening with your ovaries. And it's only when you holistically take all of that together that you start, really identifying or that there might be issues that you didn't know about, right? And then this is the step one. So it's doing really the reproductive intelligence review and getting an understanding, not just of the woman. The man will contribute to half the problems when it comes to struggling to conceive.
Whenever you try and introduce new ideas into the culture or into the industry in any field, there's usually a lot of resistance. I'm very curious to know if you faced that kind of resistance and skepticism and what you did to overcome it.
Healthcare, not just fertility, but healthcare as a whole, is really difficult to introduce modernization.
Mm.
And we see that with the challenges that we see on the news with the NHS, and with the. So it's throughout healthcare that we have these challenges. And we do need to have a better approach to how we introduce innovation in a responsible manner. So my first attempt to do this was not to build avenues. My first attempt, I was either a co-founder or an executive director or a chief something officer, either clinical or scientific, of about 13 different startups that I've been involved with, each of them trying to solve one part of the fertility journey, whether it is let's use AI to improve to predict the quality of the eggs, to predict the implantation potential of embryos. Let's look at the sperm. Let's build robots to improve the quality of how we freeze our eggs and embryos so that they're stored in the world's most precious cells. How do we keep them safely? Until now, we were just storing them endures that were designed to store milk, right? From the
Wow.
dairy industry.
Oh,
And
God.
we're like, no, no, no. These are important cells. They deserve a technology that's going to maintain their integrity. So after all those horror stories of things going wrong that we've seen at a global level, we thought that the way we store eggs and embryos in a traditional clinic is not good enough. So we spent a lot of money raising money to develop these technologies, get a lot of specialists around the table and we really struggled with each of these companies to get them into the market. And mainly because, I mean, it depended on the different markets. Some of them is because the doctors just didn't have an understanding of AI and technology and the mathematics aspects. There was this, if it ain't broke, don't fix it, or I've never needed this before and I'm making babies. 24% live birth rate is good enough. And there's just a resistance to something that you weren't trained on and don't understand. There was a fear that this is going to replace us, which is never going to be the case. Fertility is too human, healthcare is too human. There will always be a human delivering the technology. Technology is there to make us like having more superpowers than we had before, so we can see things that we couldn't see before. But that resistance has always been there. And the main issue has been that how we've been trained as healthcare practitioners to validate new drugs, we feel that we need to test digital technologies in the same way as how we validated drugs. But that's not the intervention. That's not how this technology is used. It's really, as I said before, using the AI doesn't improve the embryo. It's just telling you, it's like putting a thermometer in. Putting a thermometer to measure your how sick you are is not going to make you better.
Yeah.
But the fact that you discover that you've got a high temperature, now you take paracetamol. Paracetamol is what's going to make you better, right? The AI is a thermometer. And without the thermometer, we don't know where the sickness is. So we need that first step to then start identifying the right interventions that come in. The problem is that we've been running and testing and validating AI-driven technologies as if it's the paracetamol. It's not the paracetamol. It's not going to improve the embryos, and it's not on its own without an intervention going to improve your success rates. But if you apply that knowledge that comes from the AI into the clinical decision-making, that's where the difference comes in, right? And this has been a huge misunderstanding in our field, that as healthcare practitioners, we have not been trained on the mathematics behind how to validate data-driven solutions.
Yeah.
And that's the reason why not every clinic in the world is using AI data-driven solutions, right? So we built avenues partly to be that catalyst that will start getting every other clinic in the world to modernize. Every week we have visitors that fly here from across the world. We've had most of the groups of clinics from around the UK that we're bringing over going, look, it's not as scary as you think. It actually makes your life better. It's not going to make you unemployed. This is something that's going to make you a better care provider to your patients. You should be using it. I would almost go as far as to say it's negligent not to.
Yeah. I can see why that analogy is so helpful. It's the thermometer. It's not the paracetamol.
Yeah.
Hi, everyone. Just a short break to say thank you so much for listening to the episode. I hope you're enjoying it. If you are, please do hit the follow button. It means so much to me and really makes a difference to a new podcast like this one. Also, I would love if you could leave a rating and a review. When you're creating in a vacuum, it's not always apparent whether the episodes are resonating or not. And that's why your feedback is so important to me. It means that I can actually put out episodes that you want and will enjoy. Thanks so much. Back to the episode. So interesting. I'm so interested in this, and I feel like it's really going to change a lot of people's lives. I was also thinking as you were speaking, like just that kind of transparency and information that you get about your own body, which is missing without those kinds of tools.
And it goes a bit beyond that as well, because there's so many decisions that a patient has to do during their journey. And usually, like a really hard decision is it time to stop?
Yeah.
I've done 12 cycles. I've done 15, 8. I've seen a patient this morning. She's done 8 cycles of IVF elsewhere. She's now being treated with us. But that's a long journey. Okay, that's a few years
Yeah.
of their lives. This takes over. Yeah, this takes over your ability to focus at work, your ability to have fun when you go out with the girls. It takes you can't even sit down and enjoy a movie because your babies keep popping up inside the movie, right? So this is something that it really uh, puts you in a situation of what I don't even know why this is happening. So the ability to identify the why is something that when I was originally trained 25 years ago as an embryologist, I was told the why doesn't matter, Christina. Let's just get the patient onto the next cycle. The why doesn't matter. And that's how I was coached. And it wasn't until I started doing focus groups with patients where the patients was not having a baby hurts, but not knowing why is worse. Okay. And that for me was an enlightenment that it went against every dogma that I've been given in my career up to
Yeah.
that point. And the more patients I spoke to, I realized this wasn't just that first patient, it was a pattern across the board. So a lot of the things that we do with AI is trying to preempt the bad news. So rather than the patient going through this huge emotional roller coaster, we stabilize that roller coaster to give them a more plain emotional experience. So that experience goes towards the convenience of how they are experiencing the treatment. This means that your emotional battery, because you only have so much power in that emotional battery, doesn't get drained unnecessarily. So we try to cultivate that battery as much as possible and not waste it where it's not needed by using the AI to support the patient. So a lot of people think of AI as something that it's cold and something that is has no personality, but here we use it to make us more human,
Yeah.
to make us more compassionate, to make us, you know, understand the patient better. We can look at the words the patient's using to look at and measure the positivity and negativity of the words, for instance, so that we can start identifying this particular patient needs more supports and this let's bring
Wow.
a counselor to have a conversation. We record all of the consultations, so we're looking at the types of words being used. We also use it to kind of improve our service. So if we have a few people going, I'm struggling to find parking, so I'm going to be late for a few minutes and stuff like that, we see that across the board and we can say, okay guys, there's an issue with parking, let's go try and figure this out. So there's lots of things that we can do so that we can predict the needs of the patients before they have the needs themselves. So this is one of our it's one of our core values. It's something called omotenashi. I've consulted with 250 clinics around the world to try and improve the standards of care. So this is in over 20 countries. And one of these countries was Japan, where I've spent a lot of time. And it's one of these places that I've gone there to teach and to improve standards of care, but I left learning more than I taught. It's one of those
Yeah. Japan.
experiences where I'm obsessed by the Japanese culture. You can see behind me here, that is the first Japanese time lapse system in the market that has come to Avenues first. Because we really like that Japanese culture, the quality of the products that come from Japan as well. So, omotenashi, the closest word we have in the English language, which is completely antiquated to it, is hospitality. But hospitality is, you come in, they say good morning, everybody says please and thank you. No, omotenashi goes beyond. It's about looking at a person, anticipating their needs, fulfilling the needs they didn't even know they had. So when you go to have Japanese tea, for instance, it's the devil's in the detail of your experience. So when you come here at Avenues, you will notice a particular smell. You leave the hustle and bustle of London, you walk into a room, the sound is already a sound made to make you relax. And there's a smell, and the look and feel of the place is designed to make you to put you at ease. Okay, so this suddenly feels like it's not a spa-like feel. It's not sedentary. It's more like you finally got home and you can finally now focus on your well-being. You can finally have a discussion with about what's happening for you. It's about anticipating what is the cup of tea that you need. Like the patients mentioning that their favorite song during their scans is this song, and then that song is magically playing during their embryo transfer. It's creating those little magical moments that just bring joy,
Mm.
just ultimate fulfillment and joy.
How wonderful that you've adopted that and kind of taken it into the culture avenues.
Yes, it's something that what we have here at Avenues is we've handpicked the best. We've never advertised for a doctor, nurse, or biologist. We've handpicked, we headhunted. Each individual person that's here is somebody who understands the value of technology, but most importantly of all, has that compassion to speak to the patient and connect with the patient and make the patient feel heard. And that's a skill, right? That's not everybody has that skill. And this is something that whoever you speak to here in the team, you will get that omotenashi experience all the way through. Because we believe, I have no scientific evidence to back this up, but we believe that this contributes to your success rates. Okay? We believe that by giving you a better experience and by putting you in that state of joy, that you're more likely to get where you want to get to.
That's wonderful. I've read recently a little bit about embryonic testing. I know that you have examined this and have views about this. I was going to ask you if you wouldn't mind talking a little bit about that.
So this is highly controversial, but I'll explain first why it's controversial. And then I'll go into why we're backing it and why we think this is in the best interest of the patients. Okay. So there are three different ways that we can look at genetics of the embryo. Okay. The first two that I'm going to tell you are completely legal in this country. We do it routinely. Okay. So if you imagine like a pack of cards, okay, and you're trying to see if you have the right number of cards in hearts, in diamonds, in clubs, yeah, that is what we call PGTA, which is pre-implantation genetic testing for aneuploidy. You've got the right chromosomes in the right place. Okay, so we're looking at that sort of level in a pack of cards. And this means that you're less likely to have a miscarriage and more likely that this baby is going to implant and lead to a baby.
Yeah.
Okay, so that is called PGTA, very routine. We do this a lot on a daily basis. I think we do about, I don't know, about 20 or so embryos a day are being PGTA tested to give you an idea on the volume of it. The other thing that we do with it is the genetic testing is called PGTM. So for this one, we're looking at, does it have a particular genetic condition of a genetic disease that we know runs in our family, right? So things like Huntington, for instance, or BRCA. So if you're imagining that metaphor of the pack of cards, it means one of those cards, maybe the three of hearts, is damaged. It's ripped a little bit, right? So we need to find an embryo where the three of hearts is not damaged. We need to find, so let's, depending on the genetic condition, different proportion of your embryos are going to have that damage because you carry that condition. So in some cases, it's a quarter will not be affected. In other cases, 3/4. So the proportion varies, but the idea is create several embryos, choose the one that doesn't have a genetic condition.
Yeah.
So we're not able to fix the embryo, but we're able to pick the one that didn't inherit that from the parent and transfer that one instead, which means the parent will carry the condition and then they will know they haven't passed that on. So it's something that not everybody needs to do it, but for people who carry severe genetic conditions and where the UK government has established that genetic condition is severe enough that it is ethical for us to screen embryos for it. So you couldn't do it for, I want somebody with blue eyes.
Yeah.
Okay? It would be something that has a severe impact in their health. Then this is, and we got at the moment 1,900 genetic conditions on the list. Things like severe heart conditions, that will significantly reduce the lifespan or the quality of life of a person. So this is a beautiful thing that we can do with science and bypass some really severe health conditions. So that's great. So these two are not controversial at all. This is routinely offered. It's been routinely offered in the UK for a long time. The UK has been a pioneer in these technologies. Now, the one that's a bit more controversial is PGTP. The P stands for polygenic. That means that instead of having a little ripped card, what it's looking at is you have several conditions around your genome. So in the analogy of the pack of cards, if you shuffle that pack of cards, you're looking at the pattern of how the cards are next to each other. So certain genetic conditions are not caused by a single gene. They're caused by a sequence of genes together, scattered around your genome. So what we do is we look at the entire genome, and then we run it to see what is the risk of you having this medical condition. The controversial aspect is that we're now going into the realm of genetic conditions that are partly caused by the genetics and partly caused by your environment that you're going to be in. So things like type 1 diabetes, type 2 diabetes, schizophrenia, several severe heart conditions, right? All of these fall into this realm. So it's less controversial to be screening for these things. But when you're applying a technology that's looking at your whole pack of cards, we can also look at the color of your eyes, we can look at your height, we can look at how intelligent you're going to be. And that's when it starts getting a little bit dodgy. You're able to screen for things that maybe society won't be comfortable screening for. For instance, IQ. Are we comfortable for people to screen your embryos for IQ? Some people say yes, some people say no. The law says no. The law is very specific and it says that's not a serious medical condition. And secondly, IQ is something that it'll give you a chance. It will tell you have 80% chance of having a higher IQ. It'll give a score of a risk, right? The problem that I have with this being illegal, there's two of them. Firstly, if you are a person who has type 1 diabetes, you know what it's like to live with type 1 diabetes. And I think that you should have the opportunity to access the technology, because the technology exists, to be able to screen your embryos for type 1 diabetes. I think that type 1 diabetes and type 2 diabetes, they are severe enough, similar to other conditions that we already approve in our single gene disorder. So BRCA, for instance, is you have now twice as much chance of getting cancer, right? If you have the BRCA gene. But it doesn't mean you're going to get it. It's not for certain that you're going to have cancer, but you have a significant increase in your chances of having certain types of cancer. So that's also done on a risk per se. But what we have here is the BRCA gene person, they can access the technology if they want to. They don't have to, but they have the choice. But the type 1 diabetes person does not have that choice. Now, given the technology exists, I think that person has a right to have that choice. And I think it would be ethical for them to have a balanced right to another person who has BRCA. Okay, so for me, that's one of these situations. There is the risk, and I understand the concerns that everybody has with eugenics and starting to screen now for IQ, hair color, gender, etc., etc. However, there's an ability that we could decide you can have this technology for these situations, but not for others. And that, I think, would be, in my view, more acceptable. The challenge that we have right now is that PGTP has evolved now to the point where you don't need to go to a clinic and ask to have PGTP. What you do is you do one of the other two tests that are legal in this country, PGTA or PGTM. And from that, the raw data of that information can now be used to do a PGTP analysis. So what this means is that patients, and we've had 2 cases of this already, are going to the genetics provider that ran the test with us, and they're saying, under GDPR, you have to give me that data. And that's true. Under GDPR, the genetics lab, at the request, releases the raw data. Patients are now taking this data to an American company where this technology is legal, okay? And there they're having the analysis done. And there they're knowing which embryo has risk to have whatever on the spectrum that the Americans are allowing, because in America, this is unregulated. But these embryos are in the UK, right? So now we have a situation that is completely illegal, but patients are accessing the technology in a legal manner where we are not involved in that part. We're just doing normal PGTA. The genetics lab is not illegal in releasing the information. It would actually be illegal not to release it. And the American company is doing these tests in America where this is legal. So there's this loophole that's being generated. What is illegal is for us as the care providers to access that information. So now we have the situation where the patient has medical data that their doctor can't have.
Yeah.
So that patient is unable to contextualize it. So that is what we be providing. Providing, here's more data about your care. You need to understand the context of it. We need to provide you guidance. We need to provide you support. We need to see how this fits with the rest of your healthcare, right? Because the geneticists in America know nothing about their history and their healthcare. We know the patient because we're treating the patient. So now different people are giving the patient different pieces of information, and the poor patient is having to put it all together. And that I think is wrong. So where we have this loophole where the patients are accessing this information legally, I think that we should accept the fact that one, making it illegal is unenforceable as it currently stands because data doesn't know the boundaries of a country. Yeah. And so if it's unenforceable, then we need to figure out, is this law putting the patients in their best, safest environment? And our answer is no, because we're feeling blind in our ability to treat the patients. You also have the situation where in America, because it's unregulated, you might have very high quality companies that are doing these tests. So one of the companies that I've met is called Harrisite. I trust the people behind it. I think they're fantastic geneticists. They have a huge number of experience behind them. But you have other companies that they're more like cowboys. Okay. So now we've opened this door for patients to be exploited, where they wouldn't be able to receive that support. So that for me scares me, and that is why we are trying to generate a national conversation around this. I know the potentials for eugenics. I believe those can be mitigated. And I am not in favor of people screening their embryos for IQ. In fact, I'm not in favor of people doing PGTP to begin with. If it was my embryos, I wouldn't do PGTP. But I am in favor of people having a choice. And I'm also in favor that if they're going to have that choice, that they need the proper guidance and support from their healthcare professional.
Yeah.
And that's not the reality today.
I can see how that is tricky and why you might feel that way. Aside from type 2 diabetes, what else would PGTP give someone the ability to screen for?
So things like schizophrenia is one that they've got algorithms for. A whole range of health conditions associated with your heart, serious ones, and also a whole range of cancers and melanomas and so on. Okay, so there's a whole plethora of equally serious conditions as the ones we currently approve. And I'm not sure I'm comfortable with us making a decision based on the technology being used rather than the severity of the medical condition being screened for. I think it's just a technicality, the fact that this is single gene and that's polygenic. They're all doing on risk anyway, but for me, that doesn't sit right, and it doesn't feel that it's ethical. So we're being quite loud about it at the moment, mostly because the two patients that came through don't want to be known publicly. And it was really interesting to hear their perspective. Now, one of them did want to screen for IQ, which I personally wouldn't endorse. But for them, it was about, it's my embryo, it's my body. Why should a government decide which technologies I can access or not? Now we need to make a balance of what feels more right.
Yeah.
And right now, the situation we're in today, I feel causes more harm.
Such a tricky area, isn't it? But yeah, it's just so many issues. And is that something you're actively sort of lobbying for?
Yes.
Yeah.
So we've written to the HFEA about this. We have spoken to The Guardian and The Telegraph and The Observer. And we've spoken with the BBC, Radio 5. So we were live. We were interviewed by the LBC last Sunday as well. So it's been a very busy week for us on this topic, because it really, the interviews usually start with, are you doing eugenics? And it ends with, okay, now we understand that there is a larger problem here, which goes beyond autonomy. I think it's more about fairness, and we have many examples in IVF where fairness is not where it needs to be. But I think this one is a fairly big one. And where technology is evolving so fast, and I don't think it's a surprise that the first two PGTP cases came to Avenues, because we're known for the innovation and we're known for bringing technologies here first. So I don't think it's by mistake that they came here, but I sympathize with the needs of the patients, and I sympathize with the fact that the restrictions are not to the benefit of the general public. It also, I know there needs to be a line. This we do, this we don't. But right now the line is a zigzag. And we're really hoping that the the Minister of Health and Parliament will reconsider rewriting the law, because that will need the legislators to rewrite the law to allow this technology to be accessible by the British patients. But not just that, this could bring so many benefits to the NHS as well.
Well, on top of your day job.
On top of everything else, yes, on top of making babies, we're trying to make the world a better place.
I can really tell that this is your life's work. You know, when some people talk about something with so much passion and it really is your life's work. And I'm so curious to know, what does this work bring you? Is it rewarding? I'm sure it is, but tell me a bit more about how it feels for you.
Look, this is the 13th clinic that I built. Okay. And each time that I build a clinic, it's better than the one before. And then we're learning and incorporating more innovations and more technologies and so on. I love the fact that we keep pushing our own boundaries, right? I love the fact that we're improving ourselves. We never reach perfection. Okay. We're just always striving to get closer to it and, keep aiming higher and higher and higher. And it's just generated this enthusiasm of just making the world a better place with each little improvements that we bring on and making ourselves obsolete. I've given you one example of this interview, but I've made myself obsolete so many times. I've gone into projects that made 10 years of my work or my entire PhD suddenly be shelved and be completely useless. And that's good. That's evolution. That's innovation. That's what we need to see more of. We shouldn't have a fear of change. We need to embrace it. We need to experiment. This didn't work. Let's try again. Okay, that one worked. Now let's keep going on this path and try something else that is new. And this ability to be in this continuous learning pathway. And I didn't know that. That's pretty cool. We get that on a daily basis, and I love that. That's my drive. My drive is we're always discovering something new every day. And too many people out there that don't have the child that they want. We haven't finished our work. I don't think we ever will. And it's that ability to always be craving the next discovery and the next innovation, the next breakthrough. It's really exciting. And I've surrounded myself here in Avenues with people who are so much more advanced than I am and know so much more about so many of the sub-technologies that we're bringing in, that we start seeing things from different perspectives. And that's something that I really, really, really enjoy. It's the one place that I've worked at first time in my life that there's no private equity, there's no venture capital. This is, owned by a doctor, an embryologist, and we're here to kind of try to break the mold. So it's been fun, and it's going to continue to be, I think, very, very exciting.
And one more thing, if someone is listening, a woman is listening to this and going through something on her fertility journey, is there something that you would like to say to her that might help?
Yes. One, you're not alone. Okay, this is something that 1 in 6 people are going through this. 2, you have options, and there isn't a single right option for you. And if you feel that what's being offered to you doesn't feel like the right thing, go to somewhere else that will help you make your own decisions. Okay, gone are the days where the doctors override the patients should be overriding the doctors. Okay, find your own route, fight for what is your avenues, your journey, your route to where you want to get to. But definitely understand what are the things that are in your control and what are the things that are not. Okay, so have that acceptance of the things. This is the way it is. Okay, we accept it. Now we come up with a plan, right? So have that positivity. Make sure that you find a way to have joy in every step of this journey. It is very easy to be stressed throughout it. I once was told that the metabolic and what your body goes through when you're stressed is the same as you go through when you're excited. Yeah. So try to turn it into a positive feeling. Keep your head high. Be brave, be courageous, and keep going forward. And go to where you want to go. You're the driver. Okay. You're the one who decides when to stop, when to start, and where to go. So that would be my message, that, this is something that has not been the reality of patients in the past, but we would like to make that the norm going forward.
I love that. That's so powerful. And I mean, we have some time. If there's anything else you want to say, Dr. Christina, that we've not covered, the floor is yours.
Yeah, I would love to touch on one more thing that we
Please.
feel really strongly about, and it's something that we is another big unfairness that we have in the field. Patients who have a high BMI, okay, big body patients, in this country are completely denied care, and I cannot find the medical rationale for it. I can find the medical rationale for if you have a high BMI to have you tested to see if it is safe to carry a pregnancy in terms of your heart condition, if you have blood clots, if you have, can we see the ovaries during your stimulation? I can see that rationale. But to minimize patients to a number and say that, like the NHS does, like the private clinics do, and say that above 30 or 35 BMI, you will be denied care.
I didn't know that.
Bearing in mind that 11% of British women of reproductive age fall in that category. 11% are being denied care purely because of the BMI. Had they been American, we have 3,000 patients in the National Registry in America with a BMI over 50, not 35, over 50, 22% live birth rates. Nobody died. Okay. The reason why the doctors are turning down these patients is because the NICE guidelines, which is guidelines that the government put together to frame what the NHS will offer or not. So the NICE guidelines in the previous version has put down saying if a patient has a BMI over 30, they need to be counseled that the chances of success are reduced and the risks of pregnancy are increased, and they must understand those risks. Okay, that's what it states. The NHS then took that to use as a gatekeeper, to say you won't get care on the NHS if your BMI is over 30. And the private clinics, there's been an additional guidelines, not based on evidence of this is what happens with IVF patients that had high BMI. They're not basing on those guidelines. They're basing on the facts that patients that get pregnant naturally that have a high BMI have a higher mortality rate. But I'm still trying to find that IVF patient that has passed away from high BMI, because when you've done IVF, the IVF doctor will make sure they got the obstetrician to follow them up. And those mortalities that have happened with high BMI pregnancies that are conceived naturally, they have passed away not because of the high BMI, but because it didn't have the proper pregnancy care. Their obstetrics care wasn't where it needed to be. It is a higher risk pregnancy, but so is advanced maternal age. And we're treating patients who are over 40 routinely and not batting an eyelid on it. So I'm really struggling to understand. So here at Ivy News, we don't have a BMI cutoff. What we'll do is we will bring you in, we will offer you the options. We will have a discussion about weight loss and what would be the implications of that. And then we'll have a discussion of what would you like to do? Okay, how would you like to proceed? And we will present to this patient the same way that we do with any other patient. We will discuss healthy lifestyle, just like we do with any other patient. We will discuss these are your options, right, of how to move forward. But we're not going to deny care because your BMI is over a particular number. It will be because it will be unsafe for you to carry a pregnancy because you have a blood clot disorder.
Yeah.
Okay? But that is not because of your BMI. Patients of normal BMI that has a blood clot disorder would be told exactly the same thing. So we don't have guidelines on treating high BMI. That doesn't exist. We're putting those together. And I'd love to hear from patients that have been struggling, to get access to the care that they need, who don't want to lose weight and have been told, I will only treat you if you get to below a certain BMI. The irony being that PCOS, a major cause of infertility, could be the reason why they're struggling to lose weight, right? So this is, again, 11% of women are in this. So if you're somebody who's listening who does have a high BMI, please come and have a conversation or discussion with us, because we would like to explore what is the safest way to help you become a mother. You should not be denied care.
And just to clarify, aside from IVF, avenues also you cover egg freezing. What other services do you provide people?
So we're extremely strong on the urology side of things. So we have a micro teasy machine, an AI driven care for micro teasy. So what this means is that when there is no sperm in the ejaculate, we have an ability to do a surgery where you don't need to open the whole testicle. We can just go to where we need to go. So this means the recovery rate is faster. The discomfort associated with it is at a minimum. And it means that we increase the chances of finding sperm in these cases. So this is something that if you've been diagnosed with having no sperm and you have been told that the only chance of becoming a father is with donor sperm, please let us have another look because we've got some amazing technologies here specifically to help you. But also the gynae side of things as well. So we use laser to remove your polyps. We do hysteroscopies. So the general gynae care is also offered by our doctors. So general urology, general gynae. So if you're a man, if you're a woman, if you're transitioning between the two, we are here to support you with anything to do with your reproductive health.
It feels like you're really democratizing it for everyone.
For sure,
For
for
sure.
sure. That I think equality for us is something that we're definitely trying to improve compared to where the field is today.
Amazing. Dr. Christina, thank you so, so much for coming on. This has been honestly a really enlightening episode, and I'm sure so many people are going to feel the same. Thank you. I really, really appreciate it.
I really appreciate the invitation. It's such an honor to be here. So thank you
No,
for the opportunity to have this conversation with you and to shed light on some of these things that we're really trying to get the truth out there.
thank you. Really important. Thank you so much for listening. If you enjoyed this episode, please do hit the follow button and leave a rating and review. It makes such a difference, and it personally just means so much to me. Thank you.